Hello, Medicos. So today we are with new lecture that is pleural effusion, and in this lecture we will not only talk about pleural effusion but also we will see a clinical case and we will discuss that case. So I am making it more clinical oriented. From next time onwards, the lectures I will make it will be more clinical oriented with case. So coming to the pleural effusion, as you know, pleural effusion is the accumulation of serous fluid in the pleural cavity. What can cause it? The causes can be transudative and exudative. Transudative can be congenital cardiac failure and cirrhosis of liver, nephrotic syndrome, peritoneal dialysis, hypoalbuminemia, atelectasis, constrictive pericarditis, hypothyroidism, and exudative can be neoplasm, metaplastic disease, or mesothelioma. Infectious disease can be like bacterial, viral, fungal, parasitic, or TB like. And pulmonary embolism, collagen vascular disease can be like rheumatoid arthritis, SLE, and gastrointestinal disease like esophageal perforation, pancreatic disease, diaphragmatic hernia, intra-abdominal abscess, uremia also can cause it, hemothorax, cyclothorax, and MAC disease that is mostly occurs in female. Now let's see the features of transudative and exudative. Now, in appearance, transudative will be clear, but exudate will be amber color, cloudy, or hemorrhagic. Consistency in exudate, transudate, it will be non-sticky. In exudate, it will be sticky. Consistency, protein, absolute value that is pleural fluid by serum ratio, it will be less than 0 gram per dl in transudate or less than 0.5, but in exudate it will be more than 3.0 gram per dl, and the pleural fluid by serum ratio it will be more than 0.5. Lactase dehydrogenase absolute value will be like in transudate less than 200 IU per L, but in exudate it will more than 200 IU per L. Pleural fluid by serum ratio it will be less than 0.6, but in exudate it will be more than 0.6. LDH it will be like less than two-thirds of the normal upper limit of serum LDH, but in exudate it will be more than two-thirds of normal upper limit of serum LDH. Glucose in transit it will be more than 60 mg per dl, but in exudate it is just reverse, it is less than 60 mg per dl. Specific gravity it will be less than 1.016, but in exudate it will be more than 1.016. pH will be in transit it will be more, that is 7.3, but in exudate it will be less than 7.3. Leukocyte and total leukocyte individual leukocyte will be like in transudated it will be less than 100,000 per mm cube, and it will be more than 50% lymphocyte or mononucleocyte, but in exudate it will be more than 1000 per mm cube, more than 50% lymphocyte, more than 50% polymorphs, accurate, that is detect of acute inflammation. In microbiology you can see transudate is negative, exudate is positive. The exudate all the features also called as Light's criteria. Now what is subpulmonic effusion? Subpulmonic effusion is a small effusion lying underneath the lung. Clinically, detection of the subpulmonic effusion is difficult, but we can detect in the radiological feature like X-ray in PA view in erect position. It will show apparent elevation of hemidiaphragm, lateral displacement, and slight flattening of the apparent dome of diaphragm. Diagnosis of the massive pleural effusion: in massive pleural effusion, dullness extends up to the second intercostal space or above. Radiologically, it produces dense opacity of hemothorax and mediastinal shift. In radiology X-ray, you can see. Usually, it is designed at mild, less than 500 ml, moderate 500 to 1,500 ml, massive more than 1,500 ml, according to a collection of fluid in the pleural space. Massive pleuras are produced from the malignancy, congenital cardiac failure, TB, stresses of the liver, and trauma. What can be the complication of pleural effusion? Pleural effusion complication can be like thickening of the pleura, emphysema, thoracis, collapse of the lung followed by fibrosis, spread of infection like TB to pericardium and peritoneum, cardiorespiratory embarrassment as a result of massive pleural effusion, hydropneumothorax may develop after pleural aspiration, para-pneumonic effusion, it is a pleural effusion associated with bacterial and pneumonia, lung abscess, and bronchiectasis. Now, what are the investigation? How to detect fuel? If you will do to detect a fuel effusion are first the chest X-ray, PA, erect posture. If there is minimum of 200 ml of fluid uh, is there, then the detection can be through the chest X-ray. 50 ml of fluid effusion can be detected on lateral chest X-ray. That is posterior costophrenic angle blunting can be seen. And features on the X-ray will be like obliteration of the costophrenic angle, a dense uniform opacity in the lower and lateral part of the hemithorax, upper border of opacity is concave upward and highest lateral, mediastinal shift to opposite side, massive in massive effusion. And the USG you can detect when there is small as like 5 ml of fusion is there, you can detect in USG. Can differentiate loculated pleural effusion from pleural tumor or pleural thickening. Pleural fluid analysis, the lights criteria I have already shown you here in aggregate. Aggregate is the lights criteria. In this in lab we can detect all the protein, LDH, glucose level, everything we can detect, and it is aggregate lights criteria. Now the other we can do like pleural biopsy indicates some aggregate data diagnosis. Other investigation we can do it TLC, DLC, ESR, protein, sugar, LDH, amylase, rheumatoid factors. We can do sputum examination also. We can do for tubercular bacilli and malignant cell. Mantax test we can do because LTV is associated. Now what the treatment? The main part. Now the treatment will be first of all the underlying the cause. Like if the infection will give antibiotics and others, and therapeutic aspiration. We have to aspirate the mm, fluid from the pleural space to relieve the dyspnea. Not more than 1 liter should be removed at one time because it may cause the expansion of pulmonary edema. Now, incision of the chest tube is also helpful in case of rapid reaccumulation of fluid. And pleurodesis for malignant diffusion, pleurodesis can be done like retent medicine will be injected in the pleural space so that there will be no accumulation. Now, what we can do clinically? Now, let's correlate it clinically how a case of pleural effusion in respiratory system patient will be seen. Like example, a 30 years old male presented with chief complaint of evening rise of temperature for 1 month, left-sided chest pain since 1 month, shortness of breath since 20 days. Now, also the history will be like he was apparently well before 1 month. He developed pain in the lower chest left side, which was insidious on set and progressively increasing in severity. The pain was sharp and stabbing in nature with no radiation to any other side, aggravated on inspiration and on coughing and moderate in severity. It was associated with heaviness of the left side of chest. So you can see that left side is more prominent, so the effusion is in the left side. You can now keep a picture in your mind. He also complained of fever since 1 month. Now, fever is 1 month means you can see that there is seroid infection. You can keep in this mind, which was incidence set and used to increase during evening. It was mild, documented to be 90 degree Fahrenheit. Sorry, it was 90 degree Fahrenheit, 200 degree Fahrenheit. Relieved with medication like paracetamol. He was complained of shortness of breath since 20 days, which was insidious in onset, gradually, progressively aggravated, and excretion exertion on lying down and improved during sitting position. He also developed intermittent cough with the sputum production. There is history of weight loss, uh, and there is no history of suggestive of orthopnea, PND, and palpation. And there is no history of PND. You can know it is paroxysmal nocturnal dyspnea. Now the no history of vomiting, hemoptysis, hemoptysis, pain abdomen, no history of headache, loss of consciousness, syncope, etc. Past history, there is history of TB. Now you got the picture. So this past history of TB means there is infection for your. Now, no history of diabetes mellitus, hypertension, asthma, pneumonia. Family history shows no history of illness in family with no history of TB and other major illness in member. Personal history shows that he was taking cigarette 5 cigarettes per day for 10 years. So now you can take out the pack year that is years into per day by 20 because in a size of cigarette 20 are there. So 2.5 pack per year, non-alcoholic, non-vegetarian, no allergic history. Now let's do examination. When a patient come, you will do examination. So in this patient also you will do examination. First you will see the patient. So you can say that the patient is conscious, cooperative, well oriented to time, pleasant person, ill looking, sitting comfortably on bed with thin build. And now we can note down the vital. Let's say that Vital BP is 120 by 80 mm of SG. Taken on right arm in sitting position. Pulse like 78 beats per minute. Regular, normovolemic, no radial or radiofemoral delay. Condition of arterial wall seems to be normal and all peripheral pulses are palpable. Respiratory rate is 18 per minute. Regular, abdominal thoracic, and temperature is 90 degrees Fahrenheit. Taken on right axilla. Pallor, icterus, senescence, clubbing, lymphadenopathy, edema, and dehydration are present. That is PICKLE, short code. Now, when we do the systemic examination, we can see the upper respiratory examination, no abnormality detected. Examination of chest, on inspection, chest was bilaterally symmetrical, no deformity, fullness of intercostal spaces on the left side of the chest, diminished movement of chest on the left side, increased respiratory rate, that is 26 beats per minute, no venous engorgement, no visible apical impulse, no scar present, and on palpation, temperature is not raised and there is no tenderness, diminished movement of the left side of the chest, chest expansion reduced to left side, uh, epi and transverse diameter of the chest is 25 is to 30, tracheal shifted to right side. So you are getting a clear picture in mind what happened and where is the effusion is. Vocal primitus reduced on left side. On percussion, dullness on percussion, left side, left lower chest, anterior, lateral, and posterior wall. There is dullness on auscultation, breath sound diminished on the left side, normal vesicular breath sound elsewhere, no added sound, vocal resonance decreased in the left lower chest, and the CVS, when we do the CVS examination, this is S1, S2, M0, no murmur. And per abdominal, no abdominal detector, CNS grossly intact. So you can diagnose that left-sided massive pleural effusion involving lower, middle, and upper lobe, most probably tubercular origin, because he has history of tuberculosis, and left side, because there was a history, frequently the left side is having abnormality, everything in examination, everything. So this is the diagnosis. Thank you for listening. So hope this lecture of pleural effusion with a clinical picture case was helpful for you. And these notes I will put in M4PG premium group, and you can join the group in and subject wise group also in Telegram, Facebook, Instagram, YouTube, Twitter. For M4PG premium group, you can see this link. But there will be discussion only from the verified medicos and no spam, nothing. So see you in next lecture with next topic with case. I'll make sure that every time I will bring a clinical case with the notes. Thank you.